So now it's my great pleasure to turn the platform over to my good colleague, Dr. Rashida Dorsey, who's going to facilitate the opening session and introducing our really amazing speakers. Dr. Dorsey, as you heard, is the branch chief for the newly formed Statistical Products Branch of the Federal Housing Finance Agency. And she's the first statistician hired there to build a new branch. And she leads the development of products to increase public understanding of and access to the agency's data. Previously, she was the Director of Data Development and Information Products Division and Senior Advisor on Data Strategy in the Office of Enterprise Data and Analytics in the U.S. Equal Employment Opportunities Commission, EEOC. The cornerstone of Dr. Dorsey's work is expanding the awareness and utility of federal data assets to advance equity. So she's, as you all know, a leader in demographic data collection standards, data coordination, data collection strategies at the federal level, data development on racial and ethnic minorities and other vulnerable populations, minority health and health disparities, including developing, monitoring, and evaluating strategic plans for racial and ethnic populations. Dr. Dorsey received her PhD in epidemiology from the University of Pittsburgh and her MPH from SLU, St. Louis University. So back over to you, Rashida.
Thank you, Margot. Welcome to the first session of today's workshop. Part one, what kinds of biases does the field of HSR need to address? The goal of this panel is to provide a general overview and framework for understanding and reducing the impact of structural racism on research methods. Now, we have an esteemed group of leaders on this panel who will be speaking to us today. Their full bios are on the workshop announcement. So I'm not going to spend a whole lot of time reading that here so that we can spend more time hearing from them. So our first speaker is Jamita Barlow. She is the author with Dr. Rachel Hardiman of the article published last fall in the journal HSR and entitled Examining Racism in Health Services Research, a Disciplinary Self-Critique. She will be followed by Dr. Reginald Tucker-Seeley, who will describe his work, Measuring and Reporting Health Disparities. And our third speaker will be Dr. Jamita Barlow, who will be talking about the intersectionality and how this framework and perspective are being used in research. Each speaker is going to speak for up to 15 minutes, and then we'll have a half an hour for discussion. So the polling questions aren't working right now. So we're not gonna do a poll, but we do have the chat feature. So if you wanna throw in the chat where you are from, that would be great. And I'll take a look there and we can just have a sense of where everyone's coming from. So with that, I am going to turn it over to Jamita.
Thank you, Dr. Dorsey. As is customary, please give me a second while I try to share my screen. Hopefully we can get up and going. All right, can everyone see what we're working with?
Yes.
All right, thank you. 1 second, just adjusting your faces. All right, so as Dr. Dorsey mentioned, I am a co-author on this paper that came out in HSR last fall, examining racism in health services research. And the goal of my 15 minutes with you all this morning is really to take a look at why it's important to think about racism when we do health services research. Next, to talk a little bit more explicitly about what we mean when we say racism, just to make sure we're all on the same page, or roughly the same chapter of the same book when we're talking about racism, and thinking about specific examples within HSR of how these ideas of race and racism are replicated and perpetuated within our work. But also, I think that'll put us at a good point to really dive into Dr. Tucker-Seeley's presentation about how do we create research questions and research methods that are more adequately designed to address the issue of racism within health disparities research. And I will end with a little bit of where do we go from here, which will be really brief because I think the presenters following me give us a very clear outline of what these transformations can look like within our work with very practical examples. Before I go forward, I did intend to start with this, but we asked where everyone is from. I'd like to say that I am joining you all from Minneapolis today, which is the ancestral and contemporary lands of the Dakota people, and to kind of think about that as as I go through my presentation or do my work. While I focus on Black, white inequities, it's also very important for us to think about Indigenous populations and our nation's history alongside First Nations people. All right, so why talk about racism? We're researchers, we're academics, why does this matter? And point blank, it's because racism kills, and racism has continued to kill and has really shaped the outcomes in our country by depriving us of valuable lives and valuable experiences. So the chart presented here is from a 2020 publication in the Proceedings of the National Academy of Sciences by Dr. Elizabeth Wrigley Field, who is a sociologist and demographer at the University of Minnesota. And what we see both in this log age adjusted mortality and also life expectancy looking at 1900 and 1920 is that at no point in our nation's history do we see Black people having the same health outcomes or lived reality as their white counterparts. And we know from another large body of literature that this is not due to a biological failing, that Black people are not somehow more susceptible to disease or chronic illness or the social conditions that lead to reduced mortality, reduced life expectancy and increased mortality. What these graphs show us is that over the last 120 years and much longer in our nation's history, that we are really seeing a commitment and an acceptance of Black suffering within our country. And this is illustrated very well by the sociologist W.E.B. Du Bois, who in 1897, so even before this chart really captures the data, said the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation towards the well-being of the race. There have been few other instances in the history of civilized people where human suffering has been viewed with such peculiar indifference. So the question really is, what allows us to see Black people dying so much earlier and so with a much higher frequency than their white counterparts, and turn a blind eye and do very little despite our technological, methodological, and policy advancements to really address these issues? And underlying all of this is this idea of racism, specifically the idea that resources, opportunity, power, and access is determined in our society by a person's phenotypic identity, so what they look like. And when we talk about racism, I use this definition by Dr. Camara Jones, but there are different definitions, but we look at 3, sometimes 4 levels of racism. So interpersonal racism. So this, I often refer to this as like the KKK variety of racism. So mean words thrown at individuals. And next we think about the idea of internalized racism, which is not only the idea that I believe negative things said about my group and believe that I am somehow inferior, but how we also take these ideas about members of the majority group being superior. So what does the messaging from the society tell me in terms of my capability compared to people who are racialized as Black or non-white? There's also this idea of institutional racism, how specific institutions, whether it's the criminal legal system, healthcare systems, education systems, perpetuate this idea of inferiority and superiority. And lastly, we look at the idea of structural racism, which I think is most important when we think about the ways that health services research is impacted by our broader societal ideas about race and racism. And so structural racism is often thought to be a little tougher because there's no clear actor, but instead it's these mutually reinforcing systems that perpetuate these ideas of white superiority and inferiority by working in tandem to deprive certain communities of resources while being very intentional about giving increased access and ability to others. And Dr. Dorsey we started this conversation, someone mentioned housing before the webinar started, but when we think about how structural racism works, We can think about examples like the GI Bill post-World War II, a system in which our country decided it was important to support troops who were returning from war and make sure they had access to housing and kind of support the building of the American middle class through very affordable bank loans. And what we saw in this policy was still the replication of the idea that Black people are unserving and that they should not have the same access to resources. So what we saw was the majority of Black GIs, although they had the same on-paper qualifications, they were often denied access to these housing loans, which often forced them and their families to join other Black families in overcrowded neighborhoods with poor quality housing. And we know from other research that this often led to deprivation in other social systems as well. So the idea of structural racism, wow, I just sped through a few slides there, sorry about that. So the idea of structural racism is both old and new, but fundamental to structural racism is this idea of the white racial frame. And what the white racial frame is this idea that permeates our society. And so when I talk about the white racial frame and its structural racism, I'm not saying that these are things that we're always explicitly taught, but instead these are ideas that are so old and so foundational to our country. It's simply the water we swim in, and it's often difficult for us to acknowledge how this white racial frame or this idea of white superiority and Black biological, physical, and mental inferiority influence how we think about things, but also how we do our work. And so, although it's easy to think about these ideas antiquated and linked to practices like phrenology that tells us head shape, allows us to see that Black people are inferior to folks from the Caucasus or European descent, we often see ideas that are very similar, influenced by these old notions of Black physical or mental inferiority presenting itself in contemporary research. And one such example is, this is a tweet of an article that was published in JAMA in September of 2020 that claimed that the rates of COVID-19 infection that we saw in Black and white populations and why Black people were more likely, had a higher infection rate and a higher mortality rate was due to differential gene expression. And this is an idea that we can see very clearly still relies on this idea of Black physical difference to explain the outcomes that we were seeing. And it's very easy from a social and a research perspective to find yourself, if this is true, if Black people are somehow biologically different, and that's why they have higher rates of COVID-19, and that's why they're dying more. It's very easy to say, well, I'm not a geneticist. I don't have, and even if I were, I don't have the tools necessary to change the biological makeup or gene expression of this population. So I really can't do anything. So I guess this is just a persistent problem, and it's really unfortunate and very sad, but I guess Black people are just gonna die from COVID-19 more, right? Which doesn't allow room for a solution, doesn't allow room for real policy or health-based outreach when we think about how do we reduce the disparate rate of COVID-19 infection and mortality within this population. And that's really the shame and the power of structural inequity. These ideas and this racial framing allows us to more easily be complicit in the inequities that we see, because it allows us to say, these are things that are so innate to these populations. I can take no responsibility. There's no policy change that can really make things different. And so we then fall into this trap of thinking that either the differences we see are biological and we can't do anything, or that in some cases they are just unique to this population, and this population has to think about ways that they themselves can address these issues rather than acknowledging, in the case of COVID-19 and what we have learned, that there are certain social systems that disproportionately expose people to these, to COVID-19 exposures, such as occupational hazards, or people's ability to work from home, which we saw really contributing to exposure early in the pandemic. And instead of focusing on those things that we can change through policy, we fall back on these very old and very, very lazy ideas that these are inherent in biological differences. So outside of this health example, thinking about how this white racial frame additionally impacts our institutions. I briefly talked about education, but we know through what we have learned through the Civil Rights Act and Brown v. Board that in our country, historically and to some extent contemporarily, we hold these ideas of racial inferiority, and they're closely linked to both our ideas of who can learn and who can lead. And an article that I think really reiterates this and really distills this is Victor Ray's A Theory of Racialized Organizations, which argues and really demonstrates that all that stuff I talked about in terms of phrenology and this idea of Black inferiority also brings itself into our workplace, right? Because these are not unique ideas. It's kind of the water we live in. And we still, when we think about who makes decisions about hospitals, about health plans, about people in leadership positions, these ideas of which populations should be prioritized and which populations should be leading the conversation are often greatly influenced by these ideas of inferiority and superiority. And so thinking about all of that and thinking about specifically how this presents itself within HSR, in this article, we named 3 primary ways. And I think Dr. Tucker Seeley's work really gets at some of the methodological approaches that we discussed. But first is in our research questions, right? So if we think certain people are more capable of asking research questions, how does that influence the research questions we ask? Or if we think certain things about non-white populations, what are we really asking? And we see a lot of times in health services research, the goal is how do we get non-white people to look like white people, right? Because we inherently, explicitly or implicitly, believe that white populations are the gold standard, that everyone should look like white populations. Instead, what would it look like if we looked at the strengths within non-white populations? It's very rare for us to see research papers that are framed in terms of Black assets or non-white asset framing. So we see that Black populations have really good social support around X, Y, and Z chronic condition. How can we replicate the care models or the social support that we see in these populations and inform all our populations? How can white patients learn from the supports that Black patients receive? That's a very rare question that we often don't see being asked, or similar questions within health services research. Second, like I said, our methodological approaches. Do we really understand what we're asking when we throw race into a regression, or when we see that race is significant? What does that mean? Why do we put race into questions? Are we putting race into questions that it doesn't really need to be in? And lastly, this idea of how we interpret findings about race. Are we capturing biological difference, or are we capturing a social experience? And how can we present research that really calls out the social experience of racism rather than saying or presenting language that makes it seem biological, which we know that it's not. And I'm coming up on time, but thinking about the path forward, my colleagues and I have attempted to reframe how we do our work by asking these questions in a different way, in ways that instead of assuming that white populations are the ideal, how can we take into account the experiences of other cultural groups to both develop care models, but also lead where we go as a field? What do we see from this example, a community-centered birth center? What are the Black patients receiving care from Black providers? How can we replicate their needs and outcomes within other programming? And lastly, I say this with great joy, we are not the first ones to ask these questions. We're not the first ones to develop clear guidelines of how to move forward. And how can we learn from other, I think there's a lot to be learned from other scholars that have published on this topic. And I'm over time, so I'm going to stop there. But I will say lastly that I think Dr. Tucker-Seeley's work and Dr. Barlow's work gives us the concrete tools that we need to kind of reframe how we ask these questions and how we do this work more accurately.
Great, thank you, JMeg. And so the title of my discussion today will be Measuring and Reporting Health Disparities. My name is Reggie Tucker-Seeley, and I'm the Edward L. Snyder Assistant Professor of Gerontology at the University of Southern California. So as Mike mentioned, it is well established that racial and ethnic differences exist across many health outcomes. And some examples here from locally from Los Angeles, from the Center for Health Equity Action Plan, Los Angeles County Health Agency. Differences across racial and ethnic groups were noted in life expectancy, where Black residents have a 6.5-year gap in life expectancy compared to whites, and diabetes mortality, where across racial and ethnic groups, diabetes mortality is higher compared to their white counterparts, and also in difficulty accessing care, where Latinos are over 2 times more likely to report having difficulty accessing medical care compared to their white counterparts. Now, it can be very challenging to know where to begin when attempting to address health disparities. And because of the history of racism that we just heard about in the United States, the landscape can seem quite daunting. So prior to joining the faculty at USC, I was on the faculty at the Harvard School of T.H. Chan School of Public Health, where I taught a course called Measuring and Reporting Health Disparities. And in that course, I developed this framework for addressing health disparities. And the framework begins with definitions, specifically asking you to be explicit about how you define terms such as health disparities, health inequalities, or health inequities. Next is health outcomes. What health outcomes do you include? How do you make the decision about what to include? What data sources? Where would you get to the data? Is it a population level survey, or is it healthcare services related, or data directly from patients? Measures, how do you measure the differences? Communication, who is the audience for your reporting efforts? Partnerships, who should you address the recommendations to? And evaluation, what does success look like? And for our discussion today, I'm only going to focus on definitions, health outcomes, measures, and communication or reporting. And I will present a series of questions for each that begin to help us better identify where our potential biases might be. So starting with definitions, how do you define the following terms? Health disparity, health inequality, health inequity. How does your organization define these terms? And does your definition, when you're focusing on racial and ethnic differences, explicitly recognize the historical marginalization, that is racism, experienced by minority groups? Now, defining health disparities, these concepts, is a value-laden exercise, and there's no one definition that fits all situations. So it's important that you're explicit about how you and your organization defines these terms, because that helps the reader to know what you mean by these terms, such as health disparities and health equity. I think oftentimes we assume that we all share each other's definition of these terms. And so when you're explicit about your definitions, that can signal to the reader whether you acknowledge the role of racism or historical marginalization in potentially creating the differences across groups that you are reporting. So here are some examples of health disparities definitions. So first, from the NIH, where health disparities are differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups in the United States. In the CDC, health disparities are preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged racial, ethnic, and other population groups in communities. For health outcomes, how do you decide what health outcomes to include in your disparities-related efforts? So who is at the table to decide what health outcomes get included? Are community members at the table to discuss their priorities? And does funding determine what health outcomes are reported? For health disparities measurement, what is the goal? So is the goal to compare two groups? Is it a summary measure across many groups? Are you comparing all groups to the best group or to the average group? And then for summary measures, who is included, who's excluded? What does the measure mean? And lastly, what should we do about it? I think that's often the step that gets left out in measuring health disparities, thinking about what should happen now that we have noted these differences across groups. Additionally, it's important to recognize within group heterogeneity, individuals have multiple social statuses. So it's important to determine the intersection of socio-demographic characteristics of interest, where sufficient data are available to make those assessments, such as the intersection of race or ethnicity, socioeconomic status, and sex. My colleague, Dr. Barlow, will present on the importance of intersectionality following my presentation. It's also important to make measurement choices that facilitate communicating with various stakeholders. That is, as researchers, we should be prepared to communicate methodological choices and results to practitioners, researchers, community members, and/or patients. In terms of communication or reporting, who is the audience for your reporting efforts? Oftentimes we as health disparities or health services researchers are reporting to each other. And so thinking about how do we expand those reporting efforts to include the groups who are actually impacted by our findings. Is the audience aware of your definition of terms? That is in terms of how you define health disparity and health equity. And did you communicate how you measured the difference? That is, how was the disparity determined? And also, is the audience aware of when you are calling a difference between groups a disparity? So in this example, here is a bar chart that shows chronic disease death rates by race, ethnicity, and it's reporting the prevalence of 3 chronic diseases across racial and ethnic groups, where it is evident that there are differences across racial and ethnic groups. But would you call these differences disparities? And what makes these differences disparities? So our recommendations for reporting include being explicit about who the audience is. Is your audience community organizations, community residents, policymakers? Also to be explicit about what makes a difference a disparity and what makes a disparity actionable. Be explicit about how you define health equity and your goals for addressing health equity or for addressing the health disparity. And do you differentiate between whether the goal for reporting is to guide disparity reduction and/or is the goal health equity? The answer here might depend on whether your goal is to focus on group difference or to improve the worst off group. So we focused on definitions, health outcomes, measures, and communication, but as an important question to ask as one proceeds across this framework is how and whether racism influences the outcomes and also the process. That is, what role does racism have in the pathways that lead to the differences noted? And also, what role does racism have in who and how we define, measure, and report disparities? So this work is very challenging, and if the questions posed today are not explicit, there can be many assumptions made about the goals for the work. And I often read this quote from Martin Luther King from his 1967 book, Where Do We Go From Here, Chaos or Community? And I think it really highlights the struggle that we have when we start doing this work. And as we proceed along that, that pathway, if we aren't clear in that first stage regarding definitions. There is not even a common language when the term equality is used. Negro and white have a fundamentally different definition. Negroes have proceeded from a premise that equality means what it says and have taken white America at its word when they talked of it as an objective. But most whites in America in 1967, including many persons of goodwill, proceed from a premise that equality is a loose expression for improvement. And what this definition says to me is that we should be clear about our disparities efforts, and when our efforts are focused on disparities reduction, or if we are really working toward that aspiration of health equity, where all individuals have the opportunity of achieving their best health possible. Thank you. And my contact information. And I will stop sharing.
Welcome, welcome, welcome. Hello, everyone. It's my honor. Thank you for the invitation to present today. And today I'm going to talk about understanding intersectionality. And I am so excited to be able to go after my esteemed colleagues. And I might add that I think I've guest lectured in Dr. Tucker Seeley's class before. So just happy to be here. So my name is Jamita Barlow, and I'm on faculty at GW. I wear many hats, as you can see under my name. Not only am I identify myself as a womanist scholar who is a psychologist, a community psychologist, a public health scientist specializing in women's health. I'm also a doula, a yoga instructor in several areas. And I wear many other hats. The one that I'm most proud of is the mentoring and the research that I do with students, as well as the work that I do with several organizations. And so in order to talk about intersectionality, it's going to be important first for me to disrupt this process of how we give presentations. And so I start a lot of my talks with this slide. And it's a way of honoring the past so that we can really create a better future. My Indigenous siblings, they say about moving 7 generations forward, and that's really what it's about. And so my very first public health professor was Dr. Bill Jenkins, and you may know him from the work that he did to end the Tuskegee study of untreated syphilis in a Negro male. I also had a very dear friend, Kamina Davis, who was a community worker and faculty in Charlotte. And the two of them really shaped and had an influence on my life. Dr. Jenkins taught me how to use data to really create and enact change. And Kamina taught me how to always keep community first. But then I moved towards my grandfather. I like to share this picture of him. This is my father's father, who voted for the first time and made the local newspaper. I do this to remind people that it's not that long ago where Black people in this country did not have basic civil rights, and they're still at risk. I leave you with this quote from Sonia Sanchez, and I hope that you grow and learn something new in every day, including in this presentation today. So in order to understand intersectionality, we have to back up a little. Intersectionality emerges from Black feminist thought, Black feminist consciousness. And I consider it a decolonizing methodology. But before I get there, I have to tell you, what is colonization? And so it is important to note that colonialism and decolonizing that approach really comes from our Indigenous siblings. And acknowledging the land that we're on, the work that we do is an important part of that process. But to understand settler colonialism as an institution or system, you have to understand that it created this settler slave state. But built upon that was this ideology. And the last 2 presentations you heard spoke to that ideology. The way that I like to frame it is philosophy of science. I often ask researchers, what is your philosophy of science? Because typically when we jump into research, we jump into, okay, what's your research question? What's your methodology? But we miss two steps that are so critical and I think have a major impact on the formation of our research question, how we do and choose our methodology, and the way in which we engage our work. And that's ontologies and epistemologies. So I'm sharing you here, not only researchers, scholars, activists, writers, but these are womanist and Black feminist scholars, everyone from Alice Walker to Beverly Guy-Chevtal to Layli Mapayan, Angela Davis, Paula Giddings, Brittany Cooper, and Michelle Berger. And all of them have written extensively, and they come from a long line of Black women since, to my knowledge, at least the 1800s, that we have literature that speaks to Black feminism and womanism, the experiences out of Black women who have multiple marginalized identities. But fundamentally at the root of that, when you think about the structures, is colonialism and how it operates and how violence is critical to that. So you can really take this idea of violence and analyze it in many different ways that I don't have as much time to expound on today. And so when we think about decolonizing methodologies, I use Black feminism and womanism as decolonizing methodologies. These ontologies and epistemologies shape my methodology, shape my research question, and shape the direction of the work. And I encourage you to really interrogate your ontologies and epistemologies. And so there are many different definitions of intersectionality out there. Intersectionality as a term was developed by Kimberly Crenshaw. She also developed, in conjunction with others, this term critical race theory that has made the news a lot. And that's used in law mostly, but it's also been applied by researchers in many different ways. But with intersectionality, it's this idea of there literally is a multiple and reinforced effect of all of these different structures. So it's not that in this moment I'm a black person, and then I jump over here, I'm a woman, and then I jump over here and I have a certain class level or I'm able-bodied. It's that at that exact same time, I'm all of those things, and that there are structures that have an effect on that. And it comes, this is not a new thought. Everyone from Du Bois to Anna Julia Cooper in 1886 to the Combahee River Collective, a group of Black feminists who really created a lot of the terms that we use today, like identity politics, not the way it's been kind of usurped, but from Bell Hooks to Stephanie Shields to so many people who've created these ontologies and epistemologies and really built them into different frameworks in different areas. And so Elena Hankivsky has a really great article. I'm here, I like to drop, as you saw, I dropped a book that I highly recommend, and I like to drop this article that really goes through and asks questions. Who is being studied? Who is being compared to whom? Why? I use this with my students. I encourage you to use it in your work. These are ways in which we can practice decolonized approaches to this work that you do as a researcher, as a practitioner. And I also encourage you to check out this paper that I wrote, and really asking the health policy field to listen to Black women. And why is that? Well, listening to Black women means that understanding that because of Black women and the history with this country, we have multiple marginalized identities, but we don't have a single issue politics. And as a result, it's about resisting what Bell Hooks calls the imperialist, white supremacist, capitalist patriarchy. And so in this article, we go into more detail, but we also developed this framework. It's a little grainy, so it might be a challenge to see, but I highly recommend it. But what I want you to really think about, I want to offer 3 examples. And in this article, we do that, looking at COVID-19, breast cancer mammography, and Black maternal health, and how intersectionality plays a role. Starting with breast cancer mammography, understanding that they change the age over time of when women should get, or females should have mammographies. But for Black women who are more likely to be diagnosed and it be more fatal or more advanced stage, that age is too high. And so we need to have guidelines that really address the unique issues that aren't race-based, because I saw one of the questions in the chat It's not race-based, but it's really impacted by what the other speaker said, what's happening in our social determinants of health, what is the context, the lived environment of these individuals. So we have to think about that. We have to think about Black maternal health. I've written a paper about it. The fact that my great-grandmother died giving birth to my grandmother in 1924, right? Black maternal health has not just become a crisis. It's been a crisis, literally, since African people were brought to this country. And then if you look at COVID-19, the narrative in the media and how that emerged, I know we're right at time, the narrative that emerged about what was happening to predominantly Black communities, with a failure to really consider, it happened later, but early on, the jobs, the lived environments of people who were being most affected. And so when we're applying intersectionality to this work, it's important not only to resist single issue politics, but to take frameworks and really think about them differently. And that requires us to really engage and interrogate our ontologies and our epistemologies. I will leave you with this is my contact information, but also I do work with the Council on Black Health. And if you want to learn more, you can, this is the Black Health Bill of Rights that really is in alignment with what I talked about and with intersectionality. And so I know we have about 10 minutes left. I'm gonna stop sharing my screen and I think turn it over.
Yes, thank you. Thank you to all of our presenters for your excellent presentation. So we actually have, we had 10 minutes left for you guys to finish your presentations, and then we have another 30 minutes for discussion. So we're really good on time. One thing I did want to invite the attendees to do is to add questions to the Q&A, because we're going to begin taking questions from certainly from the audience. I will start off the discussion. And so for all of our speakers, if you want to take yourselves off mute, you're welcome to, or if you want to wait until you have something to say, but this is designed, sorry, for us to, I'm just looking at the chat, designed for all of us, for all three of you to help lead us further into this area. So, you've covered a lot of ground and described some very important accomplishments in your work. What would you say has been your biggest source of satisfaction?
I think as someone with maybe the shortest career so far of all the panelists, I can dive in about this article examining structural racism in HSR. In a way, it's what brought me into HSR. And I met Dr. Hardiman like a year into my master's program, and I was debating whether or not public health was for me because I felt the questions that were being asked didn't really get at these pieces of structure, right? It's not individual action, it's about systems of inequity that influence these health outcomes. This paper in various forms, she and I had been working on for about 4 years, really trying to communicate this idea of white racial framing and how it impacts how research is conducted. And I think I'm very proud that this paper, that we continue to work on it, and that when published, it's received the attention it has, because it shows that one, to me as a young scholar years ago who was very afraid that the field of health services research didn't think that this was a valuable way to analyze health inequity, I now see that is something that folks do find very important and that folks are very interested in working on and developing new research questions and new research methodologies that are really intentional. And so that makes me, feel accomplished.
I would say my satisfaction has come from working with community organizations, community partners. They actually are the sort of the foundation for the framework that I mentioned. So when I lived on the East Coast, I lived in Rhode Island, and I was on the Commission for Health Advocacy for Equity, which was a legislatively mandated body that every 2 years had to write the Rhode Island State Health Disparities Report. And the development of that report basically follows that framework. And now that I'm here in Los Angeles, I work with the Los Angeles Alliance for Community Health and Aging, and this framework is informing our development of a healthy aging data dashboard. And so not trying to take the tools that we have in academia around how we define health disparities, how we measure health disparities, how we communicate health disparities, how to take those to the community and focus on the community's priorities, and actually to see differences that are felt and experienced by community members. That brings me satisfaction.
And I think just following in line, for me, it's also really engaging with community members and acknowledging that they're the true experts. We are community, right? I think sometimes we can have our researcher or policy hat on and not really recognize that we're also a part of the communities that we're studying in some cases. And so that's what gives me great joy, I think was part of the question. I see a question right in the chat, so I also want to address that. What I learned about intersectionality and screening mammography. So over time, the ages have changed. And now I believe it's 40. But if you look at when Black women are often diagnosed, it's younger and it's more advanced. And so even though white women, again, that's getting back to the earlier conversation about gold standard, even though white women are more likely to be diagnosed with breast cancer, Black women are more likely to die of it. So it doesn't mean that Black women, there's this pathology that there's something wrong with them, but we have to really, and this gets into the methods, really tease out what's really happening in these women's lives. And that's what intersectionality teaches us, is that we're teasing out what's happening in their lives, in their environments, their lived environments. What are the factors that could be contributing, whether it's stress, whether it's environmental racism, all of these things that are contributing to why we see Black women, and that's most of the research that I do, who have increased rates of breast cancer that ends up being fatal. And what we know is that Black women, they're younger. So even in my family, I have 4 aunts who had breast cancer, and I had to fight to get a mammography. So from a very personal level, that there are structural barriers, because even if it's a family history, if it's not maternal history, it was on my paternal side, right? And so there's still a lot that we don't know about, that we're learning, but a lot that we don't know. And so if I'm having this issue as someone who knows the issues, what's happening to the everyday community person? And so we have to really reduce the barriers to ensure that people who want care and need care have access to care. And intersectionality really forces us to say, let's look at the numbers. Who's most affected? What are those barriers? What are those structures that are contributing to that? And let's find ways to remove them. It's very simple, but it is very complicated when you start really acknowledging some of the policies contributing to that.
So thank you. So we have a question from one of the audience members. For people interested in racial disparities in health services outcomes, what are 2 to 3 key questions we should ask ourselves as we are designing a research study? Anyone want to take that one?
So yeah, I can start, and I think sort of my framework in thinking about defining what health, your definitions, what health outcomes you're choosing, and your measures sort of come in, or is a helpful approach here. So one is, what is your definition of disparity? Be very explicit about it. Be explicit about what the difference is you are focusing on, and if that difference includes, or if that definition includes a description of historical marginalization. Your second question is, what health outcomes are you including, and who is part of that process of determining the health outcomes that are being included? And the third is, what measure of health disparity are you applying? Are you just comparing 2 groups? Are you comparing multiple groups? And then what makes a difference a disparity? Is it a statistically significant difference? Is it, and if it's not a statistically significant difference, being very clear about when a difference is a disparity, and then when is that disparity actionable? I think a key point that was made by J-Meg in her presentation is that, we are reporting all, we consistently report on these differences and then we move on. And honestly, one of the things that really motivates me in doing this work is attending conferences and sort of seeing these differences being presented, and then we just sort of leave the conference hall, or we present these differences as if they are givens. And I think it's important for us to think about then what happens after we've reported on that difference. What do we do about the difference, and to whom do we sort of target our recommendations, to us as the researchers, to policymakers, to community members?
And I'd like to add to that, it's also asking what you really want to study. I also see the question in the chat. Are you interested in the differences, right? Because in my work, I'm not interested in differences. I'm interested in within group. There aren't enough research studies that really just look at Black women or look at Black communities. Often there's that comparison that you're often asked, well, what is it like for white communities? And my response is that we don't have enough to look at within group difference. And so I think one of those first questions is, what are you really asking? Are you trying to find out what the nature of the issue that you're studying? Maybe let's just keep with breast cancer. Maybe I want to understand more about breast cancer. Well, maybe I want to see what happens to people who may be African ancestry, but from other countries, right? Considered Black, what happens, right? And so that really gets into this whole other conversation of biology and race, because, phenotype is a very real thing, but race is something that we've socially constructed, but it has an impact on so many other things that affect our health. And so that becomes a challenge. And so I really encourage people, are you interested in health disparities research? I'm not technically, I'm interested in this one particular group where a lot of people compare the groups. And I think that is an important question, or a question to ask yourself and interrogate. But then I would also ask you, because J-Mag mentioned phrenology, and I think about eugenics and scientific racism, those were all ideologies built on white supremacy, really rooted in colonialism. There was a purpose, there was the threat of violence, all of those things that I said earlier, that really created science and the justification for science. And so the arguments I often make, if you look at a lot of our measures, a lot of times, some of the measures that are commonly used aren't even validated in communities of color. And so we have to really look at what's happening with our measures, what's happening with our guidelines. I think about the New England Journal of Medicine article that came out last year that really went through and said these clinical guidelines, this is how you can make it more equitable. So how can we do this work better? How can we work with associations, clinical guideline makers for across the board to really assess, where did this come from? What ideologies were undergirding this? And that's a question a lot of people don't want to ask. That's the hard work, because it requires us to really think through, how are we practicing this art of health and the care part as well, and what is the effect on it? And we might have to change how we're doing things. And so I think everybody's grappling with that right now. So ask yourself, what is this ideology that you have that says, oh, this group does this group does that? Where does that come from? Interrogate that.
Okay, so I'm going to we have some additional questions, and thank you for submitting them. So there's a question about coursework. Do you see a need to include, as part of graduate studies, curricula coursework that challenges budding researchers to confront their assumptions on how their own race, ethnicity, culture influences or may introduce bias into their research? That's part one.
Yeah, so I think this question, there was another question in the chat too about, I think it was scholarships or reading that takes someone from being a health disparities researcher to being a health equity researcher. And I think these questions are connected. And I would say, as someone who is still in their graduate training, that oftentimes we don't have the theoretical frameworks to really understand why we do the work. And I think a more intentional theoretical curriculum could really change that. And specifically, a lot of my training is in medical sociology. So like Dr. Barlow, and her expertise is in this field of womanism and how we think about epistemologies. But how are we teaching specifically health services research students? How do we understand disease, right? What is the cause of disease? How do we define health? How do we define illness? And how are these racialized ideas? How are these classed ideas? My undergraduate training is in the history of science and medicine. So this very clear understanding of health is not simply an outcome. It's not ontological. It's something that's very socially constructed, and how are our social identities influencing how we navigate ideas about health, which influence the questions that we ask and the goals that we're attempting to achieve, right? So it's having coursework that allows people to say, I understand that my racial identity, my class identity, my national identity all really influences how I even define the word that is health. And I think a really powerful exercise that I've only done in one class is by sitting with young health services research scholars and saying, like, what is health, right? And how people define that, I think says a lot about how they consider their future in the field, and thinking more critically about, like, what does it mean to be in a classroom with someone who defines health in such a fundamentally different way than you? And how does that allow you to reimagine the questions that you asked or how you approach this as a profession?
So, Jamita, there was a question about, and I think it's come up a couple of times, what's the difference between womanism and feminism? Can you tackle that for us?
Yeah, so it depends on who you ask, but feminism, I would say as a term, is something that really emerged out of a European tradition and an American tradition. But if you look at from the beginning of time, in every culture throughout the world, there have been women who centered the experiences of women, who believed that, you know, whatever their sex was did not have an impact on what they could do in the world, right? And so there's this long history, and we actually go through it in that paper, so I encourage you to check it out. But when you think about feminism as it emerged here in the US, second wave feminism, 1960s and 70s, you had different types of movements happening, right? You have ethnic studies, you had the women's movement, et cetera. And what happened is you had Black women who recognized, look, my needs aren't being met. In many cases, whether it's in the Black community or whether it's with white women in this feminist movement. And so feminism is this belief that your sex should not have an impact, that you believe in social, political, economic equality. And that's not different what womanists believe, but womanism really emerges out of Black women's experiences. Similarly, Black feminism emerges out of Black women's experiences. But womanism also acknowledges it's a system, and it's a tool of a social change perspective, I should say, where, and this is the definition from Layli Mapayan, who has written a lot about this, it is a social change perspective that really engages the environment, spirituality, and how to create change in the world. And there are many examples throughout the world. A lot of them are related to what we call ecofeminism and womanism and engaging the environment and spirituality. And so I want to connect that question to some of the other questions I saw. It goes back to, what do you really want to do in this world? Right? There's some people who want that NIH grant. There's some people who want to create change in that way and study in that way. For me, I'm really committed to communities that I see being harmed and affected. And honestly, a lot of research is not helping them. And so my work is really looking for tools that are addressing the very real lived experiences that affect Black women. And we have this body of literature from the 1800s who are womanists, women who are doing this work. And I use that literature to really share and create mindfulness experiences with Black women. And I've been doing that in different countries and here in the US. And so my point is that if you really want to be disruptive, which is the point of this workshop, really think about what is the purpose and how are you doing that, and how you can draw upon this great body of literature that is often ignored. A lot of ethnic studies are ignored. A lot of women's studies are ignored. And that is really where our gems are in order to do this work that we're called to do in this moment.
So we have a question here from a participant asking, it can be challenging to propose change that is evidenced in the short term versus the long term. Can you describe examples from your own work on how to balance the two?
Can you repeat the question?
So all the panelists have discussed identifying disparities that are actionable, or what the work that you want to do that's actionable. And it can be a challenge to look at things both in the short term and the long term. And how do you balance, do you have examples of your work of how you're able to balance the two?
Yeah, I can start. I think that question presents a challenge as well, because we haven't, or we often don't decide, when a difference is actionable. So that is, we don't decide at the beginning, that is, if we see a 10% difference or a 15% difference, sort of when and how large does the difference have to be to facilitate action? And so that should be part of the discussion around sort of what comes after reporting. After we note that there are differences, how large does that difference have to be to facilitate action? I think also one of the challenges can be sort of ensuring that you have the resources for the long haul. And so there are going to be sort of parts of the process that will take years to change. So I mentioned, being a part of a commission in Rhode Island, and it's not like that Commission for Health Advocacy and Equity was created, overnight. And so usually sort of change in the legislative space is going to take years. And so trying to figure out, prioritizing, sort of areas where you can potentially have an impact versus where you can potentially have an impact in the short term, and then sort of thinking about things that might take a bit longer, that is in the legislative space. And all of that, I think, is going to be a part of balancing the resources you have available, both in terms of fiscal resources and human resources, depending on sort of what your job is. So for those of us in academia, sometimes the incentives are not there for us to engage long-term with communities to see the differences that we want to see. And so sometimes we have to balance, the ways in which we can be as engaged and as active in those longer-term goals.
Thank you. So, does anyone else want to take that before I go to another question? Okay. So there's a question here, and it's a pretty lengthy question. So I'm trying, but I think it gets to a good point. It's about data, and several of the speakers and recently published recommendations on researching health inequities recommend that researchers don't just use controls for race and statistical models without really probing the mechanisms that drive the association between race and studied outcomes. But the question, or the commenter saying that in a lot of times in HSR, we inherit secondary data where we can't always clearly see structural factors that cause health inequities. So if we're in the position where we have enough data to observe health differences, but not enough to really document the cause of those differences, is it appropriate to publish those results with appropriate discussion about the results, talking about structural factors, not attributing differences to biology? So, so the question is getting at data and secondary data, but I'd be curious in your work if you have any thoughts on data sources in doing this work, and in particular secondary data that's often, it's available, I mean, for researchers.
I can jump in on that and take a stab at it. Secondary data, again, my responses are the same. Let's interrogate who collected the data, how they collected it, who was included, you know, where did they get these questions from? I think a lot about construct validity, right? Because a lot of times, if you I look at it, my frustration in the public health world is we think it's a big deal when we get people to eat one more vegetable than the last 2 years ago, the last study that we're eating, so many more vegetables for this group. That's simply not really creating the change that needs to happen. And part of it is, again, getting back to ontology and epistemology. So when I think about secondary data, I'm asking those questions that are really rooted in construct validity and also representation. And I think that should be in the back of your mind when you're looking at data all the time is, let's see who was included. Let's see how diverse that sample was, particularly for the question you're answering, you're asking. And I think those are key important pieces of really evaluating how you're gonna address the secondary data analysis question.
I agree. And I think, oftentimes we as academics, we have, metrics we have to meet, and we have to, we are evaluated based on our papers and our grants. And so when we write papers that describe those differences, I think that the next question becomes then what do we do with those findings? What do we do? How do we then communicate those findings in a way to which the folks for which that secondary data was collected on, those differences can then be addressed? And to whom can we communicate those findings to actually do something about the differences that we've just noted? So for many of us, we have that trite, statement at the end of our, papers: policymakers should do something about this. And I spent a year in Washington as a Robert Wood Johnson Health Policy Fellow, and now I better understand the heavy lift that very trite statement is making for policymakers. And so I think we as sort of an academic enterprise are going to have to figure out, sort of who is actively involved in helping with that heavy lift for policymakers to take those descriptive studies, those intervention studies, to communicate them in a way to policymakers to actually get them to do something about those efforts. And those might be two different groups. So we might have a group that is just focused on describing the differences, and we may have another group that's working on, sort of translating those results for actually impacting communities.
So I have a question for all of the panelists. So what has been your biggest challenge in terms of conducting your studies and finding funding for this type of work?
I can jump in first, but I just wanted to add something to Alex's question. I think it's important to think about the fact that our reality isn't fixed, right? If we see in large data sets that the information we need doesn't make it very easy for us to ask the questions or get to the structural pieces, I think specifically from researchers who only have access to these large data sets, is there a way to create a substantive push to add more questions or reframe what we get in the data sets, or even ways to make it easier to add other data sources to the data we have, right? Like, how do we easily incorporate census data into some of the larger data sets we have? If your specific data set doesn't have those questions to ask to get at the structural pieces, are there other ways you can bring it in? And are there other ways to facilitate the easy integration of more structural questions or structural pieces? Into this piece about funding, I will say I've worked on a few studies that I've gotten a lot of pushback from, like an IRB, in terms of asking questions that are not, like Dr. Barlow talked about, not about the difference, but about in-group experiences. So asking research questions that focus specifically on Black women, and having a lot of pushback about the fact that in order to do a validated research study, so things like you need to have a white comparison group, right? It's not a good study unless there's a white comparison group. Or, and so things like that, that really make it difficult to shift away from this framing that centers whiteness and instead focuses exclusively on populations of color.
And I'll jump in. Oh, did you want to go, Reggie? Okay, I'll jump in on that as well, because I think again, you have to understand what kind of role that you're playing in this world, right? I am not someone who, I'll be honest, I don't seek a lot of funding. I'm the type of job I have, I don't need to fund this position. So there's a lot of freedom. So when I am applying to grants, it's something that I do for fun more so than something that I have to do. But that being said, most of my work is in industry. It's with community organizations. I work with a lot of outside industry or organizations just in consulting and really helping them understand how to do the work that they're doing better in a way that's going to be more meaningful for their communities. But as a researcher, typically foundations, when I have gotten grants, they've been from foundations. And foundations are a lot more open. I will say that when you're doing, these are hard questions. I've been trying to answer some, that's why I've been a little bit back and forth, but these are very hard questions to create this type of institutional change. It's not easy. It doesn't happen overnight. The fact that Anna Julia Cooper and W.B. Du Bois called for it in the 1800s and 1900s, and we're still grappling with it now, doesn't mean it's going to be solved in today's talk or even in the next 5 years. But what we can move the needle towards is really shaping the structural barriers, why only like 2 or 3% of funded applications of NIH are Black researchers. Why is it when health disparities research came out, it was mostly white researchers and not people from the communities that are often most marginalized? The fact that I know for a fact there was a major grant last year for Black maternal health and only one person was a Black woman that was funded. We have to really think through this process. And it's not just about just giving it, that creates a whole other conversation about giving it to marginalized groups, but we have to understand what are these markers, these measures that we're suggesting people abide by in order to receive these funds and do the work. And I found it much easier for me to actually do the work by working with industry. I'll be perfectly honest.
And then to piggyback on the comments that have been made, I would say that my funding in this space has primarily come from foundations. I have applied for NIH funding. I think what is helpful is just the recent conversation over the past year focused on structural racism seems to have increased the amount of funding available to address these issues. I think what's also helpful is NIH institutes such as the NIA and the NIMHD have specific health disparities frameworks. And so utilizing those frameworks in our funding applications sort of helps to guide and to signal what kind of research that they are open to fund.
Thank you. So I'll read another question that we have from the audience. After reading an introduction to critical race theory, I was interested to see how future research will balance allegorical versus measure-focused results. That is, the importance of stories is just as important as the stories we discover via data. What opinions and means of increasing this balance would any of the panelists like to offer?
I think that's a really, really great question. So I mentioned I spent some time in Washington, and I worked in the Senate. And one of the things that I noted was the importance of constituent stories. The importance of the constituents being able to come in and express their experience, and how that, in addition to those who would come in and present data, how having those two things together, that is the story from the constituent and also research that confirmed that experience, was very powerful in getting policymakers to move. And so I think we as researchers are going to have to learn to do, if and when we are ready to talk to policymakers, being able to bring our quantitative research results, but to be able to combine those with actual stories from the constituents of those policymakers that confirm that experience. I think that is one powerful way to get policymakers to act.
And if
So,
you,
I
was listening so much and I forgot the question. Thank you. Excellent question.
Do you want me to ask it for you again?
Yeah, because I had a response and then I was listening. I was really intently listening to Reggie and then I forgot.
Okay. After reading an introduction to critical race theory, I was interested to see how future research will balance allegorical versus measure-focused results. That is, the importance of stories is just as important as the stories we discover via data.
Right. And so this is the point I wanted to add to that. Reggie talked about his work with policymakers, and even I've done a lot of advocacy on the Hill, and you know this, like they want stories. That is what they want, the data, but they really care about these stories. But also in our field, we're trained to really, let's focus on the data. And so I saw earlier someone mentioned qualitative research. And so I will say a lot of and Black feminist, womanist scholars use a lot of qualitative observational measures and research in this work. And I think part of it is really rooted in these other ways of knowing. That's what we say, these other ways of knowing that cannot be confined to a scale. And so that allows us to really create other spaces and other models. And with technology being what it is, you see many different representations of data. And so stories are data. Yes, thank you, Mary Beth. And that's important to know. And that's really a way of amplifying the voices of the marginalized by finding ways to engage more qualitative, particularly observational data as well.
Okay, so we are coming up to the end of our session. I want to give each of our panelists 30 seconds to give us a few takeaways. And then I'll turn it over to Margot to continue on with the workshop. But thank you. And so we'll start with JMAG. Just 30 seconds takeaways for the audience.
Yeah, I think a huge takeaway is that research is never objective, that a lot of the work we do, we are influenced by the society we live in, and that in order to do good research requires us to acknowledge structural racism, its presence, and how it influences how we ask questions, the methods that we use, and the data that we kind of hold up as being valuable.
Reggie?
So my takeaway is, although it might seem so incredibly simple, I think the issue that JMAG raised around sort of asking people how you define health and how you define health disparities. We assume that we all share the same definition of health disparities and health equity, but I assure you, once you move to the space of intervention, you will recognize that we don't all share the same definition. So be explicit about how you are defining these terms. And in terms of your reporting, thinking about how much you want the reader, how much work you want the reader to do. That is, are you explicit about what your difference, the difference you are reporting, what that difference means, and when that difference is actionable? That is, when is a difference large enough for you to act?
And I'll return to my quote from Sonia Sanchez, the poet, about learning something new every day. Even if you feel like, well, this is my field, this is what we do. I think that way as well, but really I interrogate that notion for myself. How can I learn something new every day? Maybe today's workshop helps you think about biostatistics differently, helps you think about the way in which how you can use other ways of knowing to amplify the work that you're doing, or to really reinforce what you're seeing in the data. And I really encourage you to find ways to do that. And we've given you a lot of tools.